I want to invite some of my patients who have graciously and generously participated in our clinical trials and observational studies to come up over here, and also my clinical coordinators, Dr. Kaplan, Mr. Jones, and Ms. Riddle, Kennedy, Vela, and John Vargas, our coordinators. I want to start by sincerely thanking you for volunteering to come up here and share your experiences with our patients and audience here. There is no way that we could have made the progress that we have had in the past decade in IgG4-related disease without participation of you guys in research. So we have people here who have participated in observational studies. So observational studies are research that we do on human blood and tissue to understand why patients get IgG4-related disease. So some of you guys have donated your blood several times for us to look in the lab and see what is the immune profile, what kind of B cells. Dr. Stone went through the range of B cells and how they evolved yesterday. So this is what we have done with your blood work. Some of you donated blood during the COVID vaccination for us to understand if the COVID vaccine works, what is the timing of the rituximab and COVID vaccine. Thank you for doing that. And some of you have participated in clinical trials and are already in a clinical trial right now. So with that, I want to start asking you a question and then leave it open for the audience to ask you a question. So what made you decide to participate in clinical trial? Maybe two of you guys can answer, research in general. Ms. Riddle.
I'll go because I'm shy. So let me get out of the way. So my rationale...
You have to promise to see.
My rationale was twofold. One was completely selfish and one was for the greater good. So selfish in that I thought, well, I'll be able to see Dr. K every month. And I've never had that since I was in treatment, and so I'm going to go and join this clinical trial. The other was I've always been taught to help where I can, and so my participation was for the greater good. Since being diagnosed with this disease, I've wanted so badly for there to be a cure, and I thought, well, this might lead to an eventual cure. So that was really my driving reason for participating.
Yeah, thank you. Hi, Barry Kaplan, and the reason I participated was because Dr. Khosroshahi asked me. No, seriously, mine is very similar. I feel like this is still our data, our understanding, as hard as Dr. Stone, Dr. Khosroshahi, and everybody else is working. This is still a new disease, and we don't know enough. And the least I could do is go in and, give some blood and be part of it. And the same as you, it's sort of it's helping me too, but it's helping everybody in the room and everybody out there. So why not? Yeah.
Mr. Jones, since you are already in a clinical trial right now, do you want to tell the audience how it's impacting your journey with IgG4-related disease?
I'm Lance Jones. It has had a big impact on my peace of mind, I think, knowing that I am under wonderful care with John and Dr. K. You don't get to see a doctor every month without, there's no way your insurance is going to pay for you to see the doctor every month. That knowing that they are keeping an eye on what's going on with me, because it's kind of a scary thing. I don't know if you've had it a long time. Your doctors have never heard of it. They don't. I've not talked to a doctor, even one newly out of medical school, that said, "Oh yeah, okay, I've heard of that. I've heard of IgG4." They don't have a clue. And knowing that I'm seeing somebody that is at the forefront of it, that is involved in research, has really just comforted me a lot in it, because it does worry you when you find out what it can do, much less what it is doing, but what it can do to you. And again, you're probably, my first motivations also were selfish to start with. That's the first thing you think of. But then after you go and see the doctor and you know that it's contributing to other folks, to y'all. It's helping y'all, and it's helping, I'm sure there's a genetic component, so it's helping I worry about my children and grandchildren having it. So it has been a very good experience.
John Kennedy, do you want to add anything? What do you see, at least from your part and your role in the clinical trial or clinical research, that how you communicate with your patients in regards to their fears and misconceptions of the research?
Thank you, Dr. K. I think it begins with listening. It is important to understand that our patients are with us in a journey, and patients or participants are just not data points, but they are a part of that journey. I would say like partners in science. So to be able to be a part of that and to explain any kind of questions or fears or doubts or anxiety that may come with being a part of clinical research, and to be able to be there for our patients to guide them through this journey is what I find extremely rewarding, and the relationships and everything. So.
Yeah, I agree with that as well. I think a huge part of our role as coordinators is to be an advocate for our patients. So not only, do we have just relationships, we were talking last night, like these are genuine relationships that we create with our patients. And we foster them, and it is not only just the advancement of medicine, but it's also, your voice that we hear and we listen to, and we get to be your advocate, and not only just like your treatment and your management of your disease, but also in areas that you're struggling. If you're struggling to get to your appointments, if there's things you don't understand or you need more help with, we can help you get access to those resources as well.
So Kennedy mentioned relationships. I darn near needed to go back to counseling when the trial ended for me. Because these guys are so much a part of your life when you're in the trial. They're not just there Monday through Friday, 8 to 5. There are nights, there are weekends where you have a question and they say, just call and I'll respond. And they do. And they respond with such care. And so when the trial is over, or when you're no longer a part of the trial, that connection ends. And I felt a little bit of sadness, though I was able to see, still able to see John and Kennedy, for those who lose that connection after being so tightly knit together for a number of months. That's something I think that needs to be considered. What about where's Catherine? What about the mental health aspect of all this?
Maybe we can ask sponsors to add to their clinical trials some continuation for that reason.
An easy way of letting us go. A softer landing.
Okay, so now I'm gonna open it up for your questions. So do you have any questions for our participants, our volunteers here, or the clinical research coordinators? There are sometimes questions that you don't want to ask me or Dr. Stone or other, physicians who are kind of like feeling very strongly about research projects they have, and you feel like you are offending them by not accepting it, but you can definitely talk to the coordinators and discuss your concerns and fears about that.
So if you have questions, please come to the mics. And that means we have to have mics in the audience. So there should be one over there. Okay. I do have a question that I'd like to start off with. First, I want to thank you who have been in clinical trials and everybody in the audience who has been in clinical trials, because there are a lot of mitigate trial veterans here, and probably some other obexelimab trial veterans here. And it's really rolling up your sleeve, literally, to help advance science and to help your fellow patients. So a big round of applause to all of you, please. And my question is, how did you feel about the concept of being randomized? Everybody in a trial thinks, I'm going to get the new investigational agent, which is going to be better. Maybe it is, maybe it isn't. I've done trials where the investigational agent wasn't better than the standard of care. How did you feel about being randomized?
Hopeful until I wasn't.
The thing is, excuse me, but I come from a science background, and I know that this is necessary. The only way you could, you run into people that have an experience, and it's a limited sample size. It's their one sample, and they think because I did this, then this happened. That may not be that way. I mean, your grandmother could live to 120 and smoke 5 packs a day. That's one person. That doesn't mean that cigarettes don't cause cancer. So this is what has to be done.
Yeah, I think I'm exactly what you said. I knew I was going to be getting the drug, and I might not be. I think it is a little worrying, but then what I said before, you're under such close watch and good care that after a while you don't worry about it anymore. I mean, you're hopeful, but it's okay because you know they're looking out for you.
Exactly. I'm so glad that you said that. And any trial that is done that's a good one has protections built in. So if patients, no matter which arm of the trial they're in, if they're not doing well, they get the care that they need. Because there is this concept of equipoise. We don't really know which treatment is better. I mean, we have a hypothesis that one treatment is better, otherwise we wouldn't be doing the trial. But there has to be some equipoise, and then there has to be protection built in to take care of patients if they're not doing well, if they're having the disease flare, or if they're having an adverse effect.
Mr. Kennan?
I'm interested in understanding what percentage of how does it manifest itself into the various kinds of organs or the diseases that may be affected through the IgG4. And the second one is, does an IgG4 flare-up also mean that the IgG4 levels are abnormal? Can somebody with an normal IgG4 level have a flare-up?
That's actually a very good question that can be fully answered when we have much larger cohorts of patients that we are watching them over time and evaluating them based on the clinical research registries that we are following. Because you're right, many of the data that we have right now is from gastroenterologists who are just looking at the pancreas of the patients with autoimmune pancreatitis. Yes, Dr. Stone has a cohort, I have a cohort, Dr. Baker, Dr. Misami have, but a small one. So we put them together as a registry. We look at the progression and natural history of what percentage of the patients with IgG4 related disease have initially pancreas, how they evolve. We have some data, but it's limited. So that's why it's important to participate in this kind of research to be able to answer those questions more confidently. And the same with serum IgG4. Initially, when the disease was described, it was definitely with serum IgG4 elevation. We started seeing patients in our clinics. We collected, sample from these patients, and over time realized that no, not all patients with IgG4-RD flare with their serum IgG4 going up. Majority do, but it depends on the load of the plasma cells that are in the tissue. So if it is just an area that is in your pachymeninges, in very, very tiny bile ducts, you have a few cells that can cause the flare, can make you have symptoms. But if it is supposed to be in your glands, you have to have a lot of cells to produce IgG4. So the serum goes up. With the biliary, because it's tiny, you may not have elevated serum IgG4. You still can flare. But we would not have answered these questions if people like who are sitting here had participated in the registries and had let us follow their natural course and blood samples.
I have a question for the patients in the trial. As a caregiver myself, how did your guys' families or caretakers, caregivers feel about you wanting to be in a clinical trial?
So my husband was very supportive. When we got to a point in the trial where Dr. K made the decision that I had to be removed from the trial, I think, if I'm being honest and speaking from him, he felt probably a little sadness as well, because there was hope. We were very hopeful that this was a treatment that was going to work. But he was very supportive along the way. A day in the life of someone going through a clinical trial, or a day in the life of a visit, Kennedy and John can add to this, is very simple. So you go in, you get your blood work, you get the very first step is seeing Dr. K. And I took him along with that visit to contrast and show him how it's different than my regular office visits. So you come in, you see your physician, then John and Kennedy come in with 50 tubes of blood. No, so there's blood, there's urine samples, and then there's a questionnaire that you answer, kind of like I don't know, it's not a PHQ-9, is it? What is that questionnaire? Yes, several surveys you ask that are asked and answered, and then I think that's pretty much it. You go. But it's a very detailed visit. It's usually about an hour-long visit, and you go. And so I just wanted him to see, this is different than just going in. Every time I go in to see, they're measuring what's going on with my blood levels. They're measuring how this questionnaire answer is different than the last one, versus just seeing the doctor saying, "How you feeling today, Miss Riddle?" And that's it.
Mr. Jones?
Well, I was lucky because my wife's a nurse, and so she's very knowledgeable about everything. I would ask her, she's here, I would ask her to answer it, but she wouldn't talk to me for the next week at least. But no, it's been, my whole family's been very supportive. I drive, I'm from pretty far away, so it's a day for me to come, but it's been great. Yeah, my family's been wonderful about it.
I just want to acknowledge people like Mr. Jones, who drives 3 hours to get to the visit, and then we have to do an imaging, and we can't arrange it to do in the same day. He has to do it again. So I cannot tell you how grateful we are for your dedication and commitment to really progress understanding of this disease. It's not just selfishness, because otherwise there are available medications. Yes.
Thank you, Dr. K. My question is, being a patient, how do we also participate in the learning, giving blood, doing this, that? The second question is, with all these clinical trials and the therapies that we go through, is there anything that we can do holistically to curb the flare-ups? We just don't know what happens. The confusion over what to eat and what not to eat is mind-boggling. Thank you.
Thank you for your question. John, do you want to answer the first question, how they can find out what research is available and how they can volunteer?
Hi. Yes. So there are resources, like you can look at the websites, like Emory's website, which lists all the research that we are doing, or there is ClinicalTrials.gov that you can get. And we are there. I mean, you can call us, and it's a dialogue. So if you have questions that come up before research or during research, you can ask. And asking is just not like, it's like a robotic answer that you get with ChatGPT or something. That is there. But being able to talk to, we are there. And we are there to listen. And if you have any questions or concerns, or if it is clinical questions, we will pass on these questions to the physicians who will take time out of the day to respond to them. And if you have other questions that come up before the trial, during the trial, or even after the trial, we are your first line of contact as research coordinators, and we're always there listening and being there for you to answer any questions that you may have.
That was a great point that was brought up. Maybe we should talk to IgG4-RD Foundation to add a resource, a link of what researchers are available in different institutions or IgG4 related center of excellence, what kind of research they do, so patients can have a place to go to find out what's going on around them. So thank you for that question. So answering about the holistically treating IgG4 related disease, what I usually answer to my questions, which probably is not a perfect answer, we definitely need more information to be able to answer that question, is you cannot treat your flares and when there is fire in the organ with just diet and holistic treatments. You need to get that inflammation under control with medication. But after that, depending on what is the organ affected, definitely diet can help you to have less symptoms, especially if someone has the pancreas involvement. We know pancreas damage can cause low enzymes that you usually digest your food. So seeing a dietitian, making sure that you're following the right diet can help. In general, in autoimmune diseases, antioxidants and anything that is really good for your health is definitely helpful for your general health, and make sure that your immune system stays intact so you don't get a flare. But we don't have science and evidence-based data to support that. So it really comes to the art of like how your physician can talk to you, specifically knowing you. Someone who has chronic kidney disease, I tell them different type of diet than someone who has pancreatic involvement. Next question.
Hi, I think some of my question was already answered, but as Dr. Stone said, we're going to go back and talk to our doctors. My doctor knows I'm here, and so what do I tell her? How do you take participants from other doctors in your studies? Would I tell her that, like, your patients, myself and her other patients, could participate in these?
Definitely. That's a great question too. Yes. So these are, because this IgG4 related disease is a rare disease, so the sites that have clinical trials available are limited. So not every doctor who sees IgG4 patient has those clinical trials. So we do get patients from other doctors. So Kennedy can tell you how that works usually with getting the information. You want to go?
Yeah, so once you reach out to us and you tell us that you're interested in the study, usually what happens is we'll have a phone call conversation and just kind of go through the study a little bit with you, see if it's something you're interested in, get some more information about yourself, your history, and things like that. And then at some point we get more of like your clinical data sent to us, and the screening process happens. But yeah, it's really just reaching out to us and seeing if it's a good fit for you and the study as well.
So I would tell my doctor, then could reach out, or should I, as a patient,
so both.
reach out?
So I have doctors reaching out to me and asking about a clinical trial, but as we mentioned yesterday, I think patients should advocate for themselves too. So definitely reach out. Your first contact, most of the time, if it is through the ClinicalTrials.gov or the institution website, would be one of the coordinators. So I asked Kennedy because she was in the process of getting information from so many other institutions and states for IgG4 related disease. Most of the patients who are referred to us to participate in clinical trials are from out of our states. So she would contact their doctors, get their biopsy, their scan reports, their blood work, everything transferred to our center. We make sure they have the disease, and then we schedule them to come and have the visit with us.
Thank you.
You are very brave, and we are very thankful to you for doing that for all of us. My question is very basic and very simple. You were exposed to destroying your C cells. How did you physically feel losing your C cells? Did you feel any different than you feel before or after by losing your C cells?
I think, are you referring to like the B cell therapies that we were?
The B cells.
Okay, yeah, so I don't recall feeling any different. I still don't know today. I'm sure, obviously, I don't know if the investigator knows, whether I received placebo or the real deal, but I don't recall feeling any different. Barry?
I was not I had B-cell depletion therapy, but not in the study. I didn't feel the least bit different. There was no difference.
Yeah, same. That didn't notice any difference. And I did, before I was in the study, I did rituximab several times, and I really tolerated it very well. So I didn't feel any different at all.
Thank you very much. That's very reassuring.
So we take one more question and then move on to the Q&A.
In my case, I have been detected only through tissue. Everything bloodborne was not being found to be IgG4. How do we handle these types of patients, and what percentages of no blood or tissue, how they look into the factor?
Again, that's a great question. So I think we can answer that actually when the rest of the physicians are on the podium. Again, it's different. What tissue? Is it a retroperitoneum? Is it kidney? Is it pancreas? So we manage it differently. So when the blood markers are not present, we use imaging, we use CT scans, sometimes PET scans or MRIs to evaluate that and the disease activity. So I think Dr. Baker lecture that he has is about the disease activity, and he's going to touch on that in details.
Okay, thank you.
And Dr. K, I know you said one more question. I have a question for you. Can you talk about the role of the investigator in the trials?
Thank you for asking that question. So it's rewarding to be able to participate, or because we also participate. Sometimes we have investigator-initiated studies that we kind of propose and start ourselves. It's exciting as a science, but then when we put the hat of the role of a physician who is taking care of your patient, it is scary. So I can tell you that when I'm consenting my patients for a clinical trial, I usually put the hat of the physician who is taking care of that patient. I put myself in their shoes, that they are participating in this study. Yes, selfishly, it's going to help the science for me. It's going to help me to understand better if this drug is working or not, but this person is not a data point for me. This is a patient I've been taking care of him or her for many years, or even just for the first time, and I could offer them a drug that I kind of know it's going to work. It may have side effects, but I'm just offering them 50-50 sometimes in some cases a little better in terms of placebo or the real drug. So I am anxious when I'm consenting patients. I try to go through all the possible side effects and make sure they are informed, make sure that we both are making the informed decision. Instances when I kind of guess that the patient is on placebo because the drug is not working. But sometimes at some point you guess that probably it's on placebo. So those are also very anxiety-inducing times that you have to make a decision. Should I pull them out of this study and give them what I know it's going to work, or just hold on a little longer to be able to take them? So it takes a lot of time and energy to make sure that they are safe if they are staying in the study. If I know they're flaring, but the rest of their organs are okay, I may hold them in the study to get to the open label extension and give them the chance, because they already have participated in the study with the hope that it's going to work. But if there is something that I'm pretty sure it's going to affect them, I make the decision of taking them out of this study.
You said a key word, and I hope everyone heard it. It's safe. So please do the research to join a research study. That's it.
Thank you so much for coming over here and sharing with us.